physician at Johns Hopkins Hospital, and I direct the Pediatric Antimicrobial Stewardship Program. On the screen is contact information for the AHRQ Safety Program for improving antibiotic use. And if you have any questions or need to reach me after this WebEx, please feel free to use this information. And everybody participating on the call will receive a copy of these slides within the next 24 hours. The AHRQ Safety Program for improving antibiotic use is a collaborative intervention funded and guided by the Agency for Healthcare Research and Quality and led by Johns Hopkins Medicine and NORC at the University of Chicago. The overarching goal of the collaborative is to improve antibiotic prescribing practices and assist facilities with implementing effective antibiotic stewardship programs. As a reminder, the goals of antibiotic stewardship are to ensure that all patients requiring antibiotic therapy receive the right drug at the right dose and for the right duration. We feel the safety program is unique because it addresses both technical aspects of prescribing, such as best practices in antibiotic prescribing for common infectious diseases syndromes, as well as adaptive aspects of prescribing, such as safety culture, behavior change, teamwork, and communication. We know that while there are gaps in prescriber knowledge about antibiotic prescribing, behavioral issues such as fear of underprescribing and not wanting to offend other prescribers are all important drivers of unnecessary antibiotic use in the inpatient setting. The safety program lasts for a one-year period beginning in December 2017, and this program is free for all participating hospitals. We invite entire hospitals to participate, but individual units or clinical services within a hospital can also participate. So if you don't feel your entire facility is able to participate, you can select a unit, for example, the MICU or a hospital of service to participate. Most facilities with an existing antibiotic stewardship program, as well as those without an existing antibiotic stewardship program, are invited to participate. And if you do not have an ASP, we request that you identify a physician and or pharmacist who would like to be trained to assume that role. During the course of this one-year project, we can train those individuals into becoming antibiotic stewardship leaders. I should mention that we have obtained a national IRB for this project. The sites will not be required to have an IRB to participate. We believe that there are several benefits to participating. Participants will have access to antibiotic stewardship experts for coaching and troubleshooting, as well as interactive webinars 1 or 2 times per month that cover both technical and behavioral approaches to improving antibiotic prescribing. These webinars are 60 minutes in length and recorded and available on the project website for any members in your unit who are unable to participate on the calls or need a refresher at some point. The web slides are also available on the website and can be downloaded along with a facilitator guide and adapted for local presentations. Any and all members on a unit, including physicians, nurses, pharmacists, nurse practitioners, physician assistants, are welcome to participate in the program. Anticipate the commitment to the program requires about 4 hours per month, with 2 hours spent on webinars and 2 hours to meet with your local clinical teams to incorporate what you learned in the webinars into practice. And there are also 2 optional coaching calls a month where participants can call in for any additional assistance as needed. Participants will have access to a variety of educational materials, including fast fact sheets and e-learning modules that summarize existing knowledge and recommendations related to antibiotic prescribing. These will all be available on the project website. The fast fact sheets can be used for education on clinical rounds or modified to facilitate development of local treatment guidelines for common infectious diseases conditions. A variety of tools have been developed to assist with improving antibiotic use, and they will all be available on the project website. And during the course of the webinars, we'll walk you through how we feel these tools can be used most effectively. We've also developed educational pamphlets for families and patients, as well as commitment posters indicating that the facility is dedicated to safe antibiotic prescribing practices. And you're welcome to download all of these and distribute to your patients and family members. And finally, materials to assist with compliance with the Joint Commission Antimicrobial Stewardship Standard, such as sample policies for antibiotic stewardship, will be available. And I should mention that this project is endorsed by the Joint Commission. Expected outcomes of participation include improving safety culture around antibiotic prescribing in hospitals, enhanced teamwork and communication among healthcare workers and between healthcare workers and patients and families, reduced unnecessary antibiotic use, improved antibiotic decision-making by frontline staff, reduced Clostridium difficile infection rates, and improved compliance with the Joint Commission Antimicrobial Stewardship Standard. We are seeking CME to be available for physicians as well as CE for pharmacists who are participating in this program. The next few slides will provide some additional information about the approach and content of the intervention. The overarching approach to antibiotic prescribing that will be used in the safety program is called 4 Moments of Antibiotic Decision-Making. And during the course of the webinars, we'll use this framework to guide clinicians in antibiotic prescribing decisions. The 4 moments are as follows. 1, does my patient have an infection that requires antibiotics? 2, have ordered appropriate cultures before starting antibiotics? What empiric therapy should I initiate? 3, a day or more has passed. Can I stop antibiotics? Can I not therapy or change from intravenous to oral therapy? And 4, what duration of antibiotics therapy is necessary for my patient's diagnosis? This slide lists topics covered in the webinars that address adaptive issues. Note, with the exception of the title in green, these webinars are directed to local stewardship leaders as well as any available frontline staff in the unit. Thus, all participants are encouraged to call into the webinars. Of course, we understand on busy clinical units this is not always possible, so all of these webinars will be available on the project website to view at any time. Specific adaptive topics include behavioral change theory for antibiotic stewardship leaders. So this webinar is directed specifically to the antibiotic stewardship physician and/or pharmacist lead. The other adaptive topics include improving antibiotic use as a patient safety issue, improving communication and teamwork around antibiotic prescribing, improving defects to identifying defects to improve antibiotic use, improving antibiotic use by learning from defects, and sustaining antibiotic stewardship efforts. The next slide discusses the technical topics that will be covered. The first topic, highlighted in green, antibiotic stewardship program development, is a 2-part webinar targeting stewardship physicians and/or pharmacists. And this will help train clinicians assuming this role who do not have formal training in stewardship, but we also welcome seasoned stewards to join this webinar so that there's a good exchange of ideas. Other technical topics that will be covered throughout the year include stewardship of asymptomatic bacteria and urinary tract infections, stewardship of community-acquired lower respiratory tract infections, stewardship of hospital-acquired and ventilator-associated pneumonia, stewardship of skin and soft tissue infections, stewardship of intra-abdominal infections, and stewardship of Clostridium difficile infections. And for all of these technical topics, we'll be using the 4 moments construct to walk clinicians to how to approach these infections and how to successfully treat them. We believe that this program complements the Center for Medicare and Medicaid's partnership for Patient Hospital Improvement Innovation Network, our HIN initiative, very nicely. One of the goals of the HIN initiative is to reduce Clostridium difficile rates through the adoption of antibiotic stewardship. And as you can see, we believe that our program is very synergistic with these efforts. 5 pieces of data that we're requesting from participants who choose to participate in this project. First, monthly data on days of antibiotic therapy per 1,000 patient days for antibiotics commonly used in the inpatient setting. We will provide additional information on the types of antibiotics we would like information on and ways to submit this data to the project website. And we've made sure that these are very user-friendly interfaces to interact with when uploading data. We have a wish list of antibiotics that includes common antibiotics prescribed to hospitalized patients, but we understand that not facilities will be able to provide information on all antibiotics. And we will work closely with you to help you navigate that. Second, we're requesting quarterly Clostridium difficile laboratory ID events per 10,000 patient days. And for most of you, these are data that are already being collected by your infection prevention program, as they are required to be reported to the CDC. The third request is completion of 10 antibiotic review forms per month. So basically what these are 2-page forms which we anticipate take about 5 minutes per patient. And what we would envision is that once or twice a month, the stewardship team would sit down with any available frontline staff in a unit and review patients who are currently receiving antibiotic therapy and decide if the 4 moments were used in deciding if antibiotic therapy was necessary. So, for example, if you're on the 3rd moment and the patient is on vancomycin and you say, well, were there really any risk factors for MRSA, perhaps this vancomycin could have been discontinued or maybe not started in the first place. And of course, the point of this is not to chastise anybody, but really more as a teaching approach to think about improving our antibiotic decision-making for the next patient. These forms do not include any sort of protected health information, and the project team will not be asking for any PHI during the course of this project. The 4th piece of information we're asking for is a 1-page, what we're calling a structural survey, that we would anticipate would be completed by the stewardship physician or pharmacist lead, which gives us an idea of the bed size, the existing stewardship infrastructure, if there is any, etc. I would ask for this to be completed at the beginning and end of the study. And finally, we would like information on the hospital survey on patient safety. And for many of you, it's already something that employees in your facility are completing. If that's the case, we can work with you to obtain the data that's already been collected. This next slide summarizes the activities required of participating hospitals. 1, identify the antibiotic stewardship team. Even if you don't have one already, as long as you can identify a physician and or pharmacist who would like to be trained in this role, that's perfectly acceptable. 2, we ask you to identify and engage frontline staff on the unit or clinical service that you select to participate in this program. 3, as I mentioned, there's 1 to 2 webinars per month. We ask that any available frontline staff, as well as the stewardship team, joins these webinars. And then if somebody's unable to join, they will be available on the project website to be accessed at a later time. And between webinars, we ask that you identify antibiotic-related defects on your unit, come up with solutions, and incorporate them into your daily practice. And 5, we ask that you submit the requested data to the project website. Again, we anticipate that this will take approximately 4 hours per month, and possibly more depending on how dedicated your unit is to incorporating some of these webinar themes into practice. So this next slide shows the timeline for participation. We've been excited because there has been a lot of interest in this program. So we've been recruiting quite quickly. We will close recruitment once we have 500 hospitals that have been enrolled. But there is still room. If you're interested, definitely get in touch with us. And the next slide has information on the project website, as well as an email address for any questions. But again, you will receive a copy of all of these slides so you can review the timeline on the previous slide in more detail. So I thank you all for your attention. Please feel free to ask any questions, or if you need me to clarify anything that sounded confusing. I'm, of course, happy to do so. So thank you very much, and I look forward to working with many of you in the future.
Thank you. We'll now begin the question and answer session. If you have an audio question, please press star, then 1 on your touch-tone phone. You may submit questions via the chat on the WebEx console. And any questions, press star, then 1 on your touch-tone phone, or you may submit your questions via the chat on the WebEx console. The question, it comes from Christine Holz. Please go ahead.
You know, here's the thing. I can engage my antimicrobial stewardship medical director, but I can't necessarily lead her to the webinar every month. But if we make good faith effort, I'm assuming there's no being kicked off of the program?
Yeah, no, that's a great question. And of course, we understand everybody on this call and everybody who would be participating has, you know, important clinical responsibilities. So no, there's no minimum requirement for how many people need to join the calls. And of course not. It's the honor system, so we obviously hope as many people as possible can participate on the calls. For those who can't, we hope that they can access the webinars to see what they missed. But yeah, for the question.
This is Kathleen. I just wanted to add to that and say that we are getting CME credits, and those are only for if you attend the live webinar. So if you want, if participants want to get the CMEs, they have to attend the live webinar and not just view the recorded session.
Thanks, Kathleen.
I have a question that came in via the chat. It reads, do we have resources for ambulatory care settings?
Yeah, thank you for that question. So we, beginning in December 2017 for a full year, this project is dedicated to acute care facilities. The following year, December 2018, for a 12-month period, we will be doing a similar project for nursing homes. And beginning December 2019, we'll be doing a similar project for ambulatory care sites. So we appreciate the enthusiasm, but unfortunately, beginning December 2017, it's really only targeting acute care facilities.
And again, ladies and gentlemen, for any audio questions, press star 1. And also, you may submit your questions via the chat on the WebEx console. The question asks, how long does it take for the webinar recordings to get on the website?
Cass, do you have the answer to that? I haven't actually been checking.
Anita, it's Priscilla here. So a couple of things. One is we already have one recorded webinar on, on the website, and the one from this week will be available by next week. Okay. So for one that's interested in seeing one of the other recruitment webinars, that information is already available online.
If you mean the webinars for the actual technical or adaptive content, that's usually within the week. Is that correct?
Within the week as well. That's right.
Okay, I have a question on the phone. It's from Quanta Wu. Please go ahead.
Yes. We are long-term acute care hospital, LTAC. We are to participate.
Thank you for asking. For LTACs, we've been deciding on a case-by-case basis. So if you have a stewardship team or someone you could identify who'd like to be trained in that role, if you're able to provide antibiotic use data, and if you feel that this project would be helpful to you, we definitely ask you to contact us. We could discuss further, but the program is not closed to LTACs.
So I have to email someone specifically?
On the current slide that's up is the project website. If you wouldn't mind just sending a few quick details about your facility, then we can respond to you very quickly.
Yes, I will do that. Thank you very much.
Thank you. Thank you.
This question comes from the chat. It reads, for the antimicrobial reviews of 10 months, the slide 10-month unit, can you clarify or confirm which the intended number is? Thank you.
Yeah, so sorry about that. So basically what we're asking for is would like for patients a month who are receiving antibiotics, for that to be sort of a focal point for the stewardship team and frontline staff to sit down and discuss the antibiotic decision-making for those patients. It really meant more as a conversation piece to discuss approaches to management and what lessons we could learn for future patients. There's some, for example, critical access hospitals that might not have that many patients a month on antibiotics in the unit. So obviously, if you don't have 10 patients on antibiotics in the unit, that's okay. But for hospitals that do have large bed sizes, we ask that it could be, so currently we're doing a pilot project just to sort of work out some of the glitches for this, the project beginning in December 2017. And what most facilities have found helpful is twice a month, the stewardship team sits down with frontline staff, and each time they do that, they pick about 5 patients, review their antibiotics, what diagnostic tests were sent, talk about where there might have been areas for improvement. They do that twice a month. In total, they complete 10 of these forms. As I mentioned, these forms take about 5 minutes per patient, and we are not requesting protected health information. After you complete the form, we ask that they get submitted electronically to the project website, just so that we could get a sense of how this process is and how it's helping with decision making. I hope that answered the question. If not, I'm happy to clarify.
The question reads, do you have a copy of the antibiotic review form that will be used to complete the reviews each month?
Yeah, I'm sorry, I'm not sure how well you can see this, but it's a front and back form, or I guess you can make it a 2-page form depending on what's better for you, but this is basically what it looks like. It's basically making the people completing it think through the 4 moments of antibiotic decision-making as they think about a patient. So was the patient started, did the patient have an infection in the first place, something that was suspicious for a bacterial infection? Were appropriate cultures ordered before therapy was started? Was appropriate empiric therapy started? Could we change from IV to oral quicker? Could we have maybe stopped therapy sooner? Did we come up with a duration of therapy that seemed appropriate for this condition? So it goes through all of that. We do have a separate guide that talks through each question, what we're asking for, so to help clarify the questions. That's also available on the project website. And of course, the project team is always available if there's confusion with these forms. But again, it's really more meant to be a focal point to sort of think about where we can improve our prescribing practices.
And ladies and gentlemen, as a reminder, if you have raised your hand on the WebEx console, please go ahead and press *0 on your phones to queue up to ask a live question, or you can submit it in the chat box at the bottom right-hand corner. And our next question is, reads, just joined the call. How can I download the presentation?
Thank you so much. We will be sending all participants on the call a copy of these slides. So we'll receive them within the next 48 hours.
Next question is, if an institution is unable to report days of therapy for any antibiotics, does that include an institution from the program? Exclude, pardon me.
Exclude, okay. Yeah, so thank you for the question. We do want to have an evaluation of antibiotic use. So we've chosen days of antibiotic therapy per 1,000 patient days. We have a list of commonly used antibiotics that we're hoping you can obtain data for, but we do realize that for some institutions, they may not be able to provide data on all inpatient antibiotics, and that's okay. okay. I also just want to mention that the data we're requesting includes administered or ordered antibiotic data, but not purchasing data, because that's been shown to be quite unreliable. But we would ask that you're able to provide some measure of antibiotic use. If you have trouble with this numerator and denominator, please let us know, and we can work with you to come up with alternatives, or to see if there's a way that we can work with what data you already have to make it. But if you're able to provide this format for some antibiotics but not all, that's also okay.
The next question reads, do any of the webinars focus on documentation of ASP activities and/or outcome measures?
Sorry, you got cut off for 1 second. Would you mind repeating that question, please?
Certainly. Do any of the webinars focus on documentation of ASP activities and/or outcome measures?
So that's a great question. We do have 2 introductory webinars for stewardship leaders. And, you know, I say introductory, but I think the level of these work both for people who already are in the stewardship field and those who'd like to be trained in this role. And in those webinars, it's on the slide after this one, the one in green. In those 2 webinars, we do discuss all those kind of clinical measures and interventions and type of information that would be helpful to stewardship physicians and pharmacists.
The next is an audio question from Andrea Rosenberger.
We were wondering, how do you submit the forms? Is it like electronic, or scanning the form in, sending it somewhere?
Sheila, would you mind taking that question?
Sure, definitely. So the form will be available to you online. You can to a computer, you can access it via an iPad or some other mobile device. So you can submit the data electronically. If for some reason, from like a workflow perspective, you think it's more feasible to just, you know, take the hard copy forms, complete them, then you can also upload them to the website. So we basically are trying to make it as convenient as possible, you know, to complete the forms and then to, you know, send us the information.
Thank you.
The next question reads, what are you hoping to learn from hospitals that already have an active antimicrobial stewardship program? Will any data on concurrent activities need to be explained?
Yeah, asking that question. So, you know, for the programs that already have stewardship programs, and, you know, I'll use my facility as an example. I think, you know, we've worked very hard to develop local guidelines, to obtain antibiotic usage data, to provide education as best as we can. I think one area that we have not been as good with, which I suspect a lot of facilities might feel the same way, is training people to understand how to communicate better about antibiotic use, to communicate better about what therapy it is, when reasonable to stop MRSA coverage or pseudomonal coverage. I feel comfortable when it starts an antibiotic, you disagree with having that conversation about why you may not need that antibiotic. So a lot of these behavioral issues are addressed quite extensively in these webinars, I think help with those behavioral issues related to antibiotics, because a lot of prescribers know the patient probably doesn't need an antibiotic, but for fear or disappointing the family or a colleague, etc., we've probably all been guilty of giving antibiotics when we know they're probably not necessary. I think the other main area for those of us who already have stewardship programs is training frontline staff to effectively appropriate testing and treatment for common inpatient infections. So as an example, aspiration pneumonia, something that we address in one of these webinars. And, you know, my guess would be if there's 50 patients being treated for aspiration pneumonitis or aspiration pneumonia, there's probably only like 5 to 10 of them maybe that the stewardship team even knows about. So the benefit of this program would be by having frontline staff, the hospitalists, the ICU doctors, IC nurses, PAs, NPs, et cetera, have access to these webinars. Our hope would be for a lot of these infectious diseases conditions that the stewardship team really is not that involved with, or really doesn't have control over those antibiotics, particularly if they're not using a restricted agent, that we would be giving the frontline staff the tools to make decisions on how to treat them. It's one of the reasons we're excited, even for participants in our own facility, to be included in this project, is because we want to train for example, our hospitalists to make those decisions on patients where the stewardship team probably would never have been involved.
Question reads, can both the pharmacist and infection control nurse be the leaders? Our Chief Medical Officer has a lot on his plate right now and is unable to do the webinars on a monthly basis, nor able to take the lead position, but we'll still keep him in the loop of things.
Yeah, thank you for asking. No, I think that's perfectly fine. You know, we welcome anyone who wants to participate. Just because of the nature of stewardship and some of the nuances of antibiotics, it's helpful to have a clinician, so a physician pharmacist type, lead the stewardship program. It doesn't mean input from others is not valued and important, but you know, certainly if we would ask if you sign on, we would ask that your chief medical officer or some lead physician, whoever you feel is appropriate, signs the commitment that they believe this program is important, they support it. We understand if that person is not able to participate on the webinars or be as active as he or she may like. But certainly if you have a pharmacist, for example, who's willing to take the lead, that's perfectly fine. Again, you know, traditionally nursing is very important for antibiotic decision-making in a hospital, but I think we've not done a very good job in stewardship of figuring out the effective roles of nurses. We will have some during a webinar, as well as a separate e-learning module on the project website that discusses how nurses can help, that they're valued as important members of the antibiotic decision-making team. So thank you for that question. But based on what you told me, yes, you can still participate.
The next question reads, our hospital is owned by a corporate organization that provides our antibiotic usage data to use as DDD, not DOT. They are working on providing us with DOT data, but as of now, we do not have access to this. Is DOT data required for participation?
Thanks for asking that. We can work with you to see how we could possibly still work with your data, but it is strongly preferred that data be submitted as days of therapy. And part of that is that the way we would be collecting data, we have data de-identified, so that, for example, if you wanted to see how your institution is doing compared to similar institutions, you could periodically go to the website and compare your facility with other facilities that are of a similar bed size and some general demographics. So we're trying to do like compared to like as much as possible. It becomes a lot more difficult if we have very different units being included for comparison. If, as now, you only have data as DDDs and you're interested in participating, certainly still contact us. We can have a more detailed discussion to figure out what the options are.
The next question reads, curious about outcome data that we might be able to bring back to our hospital. We already track C. diff rate and ABX per 1,000 patient days. Just wondering if there's anything else.
Yeah, no, thank you. I mean, our primary outcome will be antibiotic use data. You know, for facilities that are already collecting this data, I think one benefit in terms of just the data would be see how you compare to other similar facilities. Because remember, we will have a large number of units participating in this program, so you could get a good sense of how you're doing compared to other institutions like yours. Besides C. difficile rates, the other measures we're looking at are a little more getting at appropriateness of antibiotic use and how communication teamwork has improved among frontline staff. they're slightly more qualitative in nature. You know, obviously, if that data is helpful to you, it's data we're happy to provide to you, but the extent of the data that we are collecting.
The next question reads, is there a handout for this presentation I would like to reference when discussing at our ASP meeting next month?
Yeah, thank you for asking that. So we will send a copy of the slides. We do have various flyers and other recruitment material that has been developed from this program. If you're interested in receiving any of that kind of information, that's easier than handing out a slide set, please feel free to email the address you see for antibioticsafety@norc.org, and we're happy to share that material with you.
The next one reads, so are you asking for 10 reviews per month on each unit in the facility if the facility is participating as an entire entity, or can the facility send 10 per month for the facility overall?
Yeah, that's a great question. So ideally what we're asking for, in the pilot project, that included 30 sites while we were developing material and troubleshooting and making sure that things were in order for the project beginning in December. Most facilities selected 1 to 2 units. So the ones that had 2 units, for example, found it helpful to have 10 reviews per unit. Now, obviously, as requesting that these forms be completed with the stewardship team in conjunction with frontline staff, realize that if one hospital has multiple units participating, that does place a burden on the stewardship team to complete that many reviews with so many units a month. If you are interested in having your entire hospital participate or large numbers of units, we definitely can work with you on coming up with numbers for the forms. As I had mentioned, most facilities have selected a couple of units, so it has been feasible to do 10 per unit. But please don't let that be a reason. If you're otherwise interested in participating, we can work with you on what might make sense for your institution in terms of these antibiotic review forms.
The next one reads, once you've completed the project, how are you planning to use the data?
You know, one of the really nice things about this program that AHRQ started and has funded is that the goal of this program is really not to gather data to use, to me, this is not a traditional study where we're doing research, we're gathering data, we're publishing our findings, and that's the end of it. To us, really, what our motivation is to train steward leaders as well as frontline staff to be able to make wiser antibiotic decisions. Our hope is after the 1 year is over, those who participate in the project will be able to continue to have a robust antibiotic stewardship program. Frontline staff, including new members who've joined the unit, will be able to access these webinars, learn to manage pneumonias and urinary tract infections and skin and soft tissue infections effectively, etc. So to be honest, we probably will at some point report the antibiotic use data if there were changes over time, changes in the C. difficile rates, any qualitative feedback about what would have been better with the program, what worked well, what didn't, barriers, etc. But really our primary motivation is more to give people the tools so that they can continue to have robust stewardship programs in place. So that's really the extent of our interest, I guess, in data.
The next question reads, does this program help us establish appropriate metrics? Seems to be a common question during discussions. Are there benchmarks available for prescribing practices, specific antibiotics, etc.?
That's a really great question. One of the problems with antibiotic stewardship compared to infection control is we are behind in figuring out the appropriate metrics and what constitutes normal, quote-unquote, normal use. Because obviously it's not like CLABSIs where 0 is the goal. The goal with antibiotics is not 0. And of course, we all understand that some patients need antibiotics, and stewardship is really more about the right antibiotics. I think one of the benefits with the program would be because there will be such a large number of facilities participating, the facilities will be varied in terms of their bed size, their academic affiliation versus critical access hospital, et cetera. We'll have a good sense of what constitutes the median antibiotic use in facilities that are different from each other. Now, again, it's always hard because you don't know if that use is all appropriate or not, but I think it will give facilities some sense of what might be the general ballpark of what they should be aiming for. We don't currently have data on what the average antibiotic use should be. So I do think, even though that's not the primary goal of this project, I do think we'll have data to be able to inform some of those issues. I just want to mention, right now the CDC has the AUR module, antimicrobial use and resistance module. It's a way of submitting data to the CDC. If there are any people on this phone call at institutions that are doing that, you are still welcome to participate using that format, and we definitely encourage you to reach out to us so we could discuss it further. Initially, we were planning on using that format, but we found that most institutions were having some challenges to provide data in that format, so we decided to use the more commonly metric of days of antibiotic therapy per 1,000 patient days.
The next question reads, we currently monitor certain ABX, but we'll need to know what other agents you want to collect.
Yeah, definitely. Thank you. So we do have a slide set developed which reviews all the antibiotics we're interested in looking at. As I had mentioned before, we realized that it may not be feasible to collect data on all of these antibiotics for facilities. We're asking for the data by antibiotics. So, for example, ceftriaxone data would be submitted, piptazo data submitted, et cetera, so that we can group things together or depending on what people are able to submit, come up with the most useful data to feed back to institutions.
The next question reads, are there any plans to share the data with a private company?
No, that's not the goal of the project. Again, just for anyone who hadn't heard before, we're not asking for PHI. We also would not be, if you're participating, you would be able to see your antibiotic use data compared to others, but you wouldn't know what the other facilities are when you're comparing data. And we don't have plans to submit this data to any private entity.
The next question reads, what happens if we sign up for the program but then later decide that we no longer want to participate?
We're hoping that's not the case. We really do think once you join, you'll find these webinars stimulating. During the pilot, which is sort of a smaller version of the same study, the webinars have been great. There's been a lot of really interesting discussion. People talk through patient examples, and we all discuss how we might manage those patients. So they've actually been a lot of fun. But obviously, if you sign up and you realize at some point that you can't continue, that's perfectly understandable. But I feel that if you do sign up and you participate, you're not going to want to drop out.
The next question reads, how about addressing proton pump inhibitor stewardship and the use of pharmacist-driven protocols for probiotic use during antibiotic treatment? Would these topics be included during discussions about C. diff?
Yeah, thanks for the question. So that's great. In the Clostridium difficile webinar, we are not discussing only antibiotic use, but some of these other risk factors that put patients at risk for C. difficile and other things that might actually prevent C. difficile or reduce the chances of poor outcomes. So we will be addressing probiotics as well as proton pump inhibitors.
The next question reads, can you confirm that participating hospitals and programs will be able to have access to other hospitals' data for comparisons? And how would this data be presented for comparison?
Yeah, thanks for the question. So you would be able to compare your institution to others. We're thinking, because often there's a delay in being able to submit antibiotic use data, so this will probably be available quarterly. for you to compare your hospital to others. Again, you would not know the identity of the other hospitals, but we could help you to understand a little bit about their infrastructure, like bed size, if they're academic versus teaching versus community versus critical access, et cetera. So on a quarterly basis, you will be able to compare your facility's data with other similar institutions.
Question reads, how would I locate the federal provider number for my individual facility that is required to enroll in this initiative?
I don't know if Kathleen or Priscilla knows the answer to that.
I would guess contact the hospital administration. They should probably know that. But I don't know.
The next one reads. Go ahead.
I'm going to just say yes. I think it would be helpful to sort of just contact the administrative staff at the hospital because they should have this information. If you know, for the person that raised that question, they could also just submit a question to us via the online mailbox that we have, and we can also confer with you offline, okay, about that as well.
And then reads, if we select a few units to participate instead of the entire facility, would the DOT data need to be specific for those units only? And we currently report DOT data for the entire facility, not broken down by unit.
Yeah, so thanks for the question. I mean, for the data to be meaningful, it would be strongly preferred that you provide data per unit. It definitely be the most meaningful data. If it's an issue for you and you're otherwise interested in participating, definitely feel free to send us an email, and we can always have a conversation and figure out what the best options for you might be, or ways to navigate around this. But I think for it to be meaningful data for you, if it's really just 1 or 2 units participating, it would be most helpful to have unit-level antibiotic use data.
And the question reads, our hospital service is spread over many units. Is it possible to participate by service rather than by unit location?
Yeah, that's a great question. So it's definitely possible. A lot of people who've signed up for this program are including hospitalist units, for example, or specific clinical services. And sometimes what they've noted is if, for example, the hospitalist service covers unit 4 West, 5 West, 6 West, on those units there might be some patients who are not covered by the hospitalist team, but that's okay. Even if they're able to provide use data for those units, not broken down specifically for every patient only a hospitalist was involved with, if that makes sense. So basically we're asking for you to do your best with antibiotic use data that represents the service or unit that's chosen to participate. But yes, this program is not confined to just units in a hospital.
The question reads, I know slides are available after the webinar. Is this discussion being recorded? I would like to share it with others on the team.
Yes, actually it is being recorded and will be available. Priscilla, would the recording be sent out to participants, or if not, I would ask whoever asked the question or whoever's interested in the recording to send a quick email, and we'll make sure you have a link to access the live webinar.
So typically we do not send out sort of the recordings via email because the files can get quite large. So we'll send out the slides via email, and then we will send out a follow-up email when the recording is also available online, and it's a public website so anyone can access it.
We have no further questions at this time.
Well, thank you all for your attention and for these really good, stimulating questions. Please feel free to contact us if there's something you're curious about that you didn't get a chance to ask. And for those of you during the call that had some more hospital-specific questions, definitely get in touch with us and we'll get back to you very soon. And always have a discussion if you're not entirely sure if this program's for you and you need some more details. So thank you all very much.